Welcome to Let's Talk Menopause Talks. I'm thrilled to be here. I'm Alessandra Henderson, the Senior Program Advisor to Let's Talk Menopause. And I'm thrilled to be working with this incredible team on educational programming. Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure women get the information they or you all need and the health care you deserve in midlife and beyond. Today, we're thrilled to be joined by leading cardiovascular specialist and women's health expert, Dr. Suzanne Steinbaum, for our February menopause talk, covering everything women need to know about cardiovascular health and menopause. These monthly menopause talks are really central to our education efforts to ensure that women receive the information that you need. And just a reminder, and maybe a short plug at the top, that we do have a rich library of over 30 talks on our website. So if you at letstalkmenopause.org. So if what you like today, please go to the website to find more. A reminder that all menopause talks are intended for informational purposes only. They are not to be used as a substitute for professional medical advice, diagnosis, or treatment. A huge thank you to our sponsor, Bayer, for making today's talk happen. And just another 30 seconds of housekeeping items quickly before we dive into what we are all here for. So a note on housekeeping. One, we have disabled the chat and we'll only be using it to provide you with relevant links. However, if you do have questions, and we highly encourage you to ask questions, we want this to be as useful as possible, please ask them in the Slido app. You'll see a prompt on the right side of your screen inviting you to participate. We'll really do our best to answer your questions. If we don't get to yours, appreciate your patience. And then two final pieces, there's going to be a brief survey at the end, so please do stay on to take that. We really take all of your suggestions very seriously. In fact, last month we heard that heart health was top of mind, so excited to be here. And you will get a recording of the events, or of today's event. So take notes, but know you'll have that resource. With that, I'm excited to set the stage for our Heart to Heart with Dr. Suzanne Steinbaum. Heart health is the #1 killer of women, yet it does receive far less media attention than its very flashier cousins, hot flashes, weight gain, and everything in menopause. We know that 1 in 3 women will develop heart disease post-menopause, and please fact check me on this in a moment, Dr. Steinbaum. But a majority of those deaths from heart disease are preventable. So welcome, Dr. Suzanne Steinbaum. We are thrilled and so honored to have you here to really learn from you and really kind of understand what every woman needs to know. Dr. Suzanne Steinbaum is a globally recognized leader in preventative cardiology, dedicated to transforming women's heart health. She has spearheaded groundbreaking women's heart health and preventative programs at some of the world's leading institutions, including Mount Sinai Heart, Northwell Lenox Hill, and Beth Israel. She serves as a national spokesperson for the American Heart Association and is the author of Dr. Suzanne Steinbaum's heart book, Every Woman's Guide to a Heart Healthy Life. And because that's definitely not enough to have on your resume or to keep you busy, she's also the CEO and founder of Advocacy, a cutting-edge technology platform revolutionizing personalized lifestyle management and empowering women worldwide to achieve optimal cardiovascular health. So it's a long intro, but welcome, Dr. Steinbaum. Thrilled to have you here, and really just excited to open this up and maybe hear in your own words, your own journey and why heart health.
I love that I'm joining you today during Heart Month. This is always an exciting month for me, getting to really educate women about their #1 health threat. I didn't know what I was going to do when I always say I was a baby doctor. I was so young and I was really enthusiastic and I wasn't 100% sure where I was going to land. And there was one day that I was in the emergency room and there was a 53-year-old woman. She was brought in. She was clearly uncomfortable. She was holding her chest and her stomach and sweating and really like sick. And so the doctors, now these doctors were also my teachers and professors, and I really looked up to them. And we went to evaluate that woman together. and they said she had gastroenteritis, inflammation of the stomach. And they put her in the corner of the emergency room where she proceeded to have a heart attack in front of us. Now, we all heard maybe of Oprah talking about that aha moment. I promise you, everything stopped. It was like everything went dark. There was a shining light. I'm looking at this woman. I said, my God, that is what I'm going to do. I am going to prevent heart disease in women. And I went to the chief of cardiology and said, I want to do a fellowship in women and heart disease. And guess what he said? There's no such thing. Because at that
Shocking.
time, at that time, 20 plus years ago, I have to count it. One day I will count how long it's been, but it's 20 plus years. There was no such thing. And I said to myself, well, if I can't do a women and heart disease fellowship, I'd like to do a preventive cardiology fellowship and really prevent heart disease in women. And I said, can I do that? And he said, there's no such thing. And so I was in the right place at the right time. He got accredited through the National CGME Medical Institute for me to do one of the first preventive cardiology fellowships in the country. And I learned about the development of cardiovascular disease in women. And that's how I established 3 women and heart health programs in 3 hospitals, because that has been my purpose, my passion, and my mission.
Wow, it's an incredible story. And thank you for pioneering this. I know so many women are going to be the beneficiaries of this. Maybe we could just start with the basics. I named some stats at the top of this, but really, if you could just, maybe as simple as what is heart health, or, what are some of the stats that we should know at the top of this as the intro to heart health?
I really talk about 3 of the basics. 1 in 3 women die of heart disease, more than all cancers combined. Think about that, more than all cancers combined. We know that women less than 55 years old, there is an increased rate of heart attacks and cardiovascular events. This is a very scary statistic that we're seeing a trend. 70% of women don't even know they're at risk or at sick. So this education is so critically important. But here is the biggest issue about this that makes me so excited to empower you with: 80% of the time, it is preventable.
Amazing. I know briefly before we were talking here, what we could talk a little bit about the history before we look forward and empower women and what they can do. But why are these stats so bad?
I think it's kind of important to understand this, because when we sit here and we look at the women and heart disease situation, why is this happening? I mean, all of us got the pink ribbon message, right? We all know to get our annual mammograms, but what has been the deal with women and heart disease? And it wasn't until 1993 to the Office of Women's Health opened up, when it was determined by the government and the NIH that in research, women needed to be included at least 50% of the time. Well, why does that matter? Because all the research prior to that was done on men. And the outcomes were then extrapolated to women's hearts. Well, guess what? We're not men. And so we started dying of heart disease more than men in 1984. I always joke around, that's about the same year where we entered the workforce equally as much as men. And yay, we broke the glass ceiling and got their disease too. But the truth is, it was really about that research that was not done on women. That's the first problem. The second problem is that in medical schools, doctors were not told that women get heart disease. And I will tell you, it was not part of the conversation. We never talked about menopause. We were told women don't get heart disease, it's a man's disease. And the doctors out in the world, in the community, that have been treating and taking care of women up until now, really were missing the boat and misdiagnosing and kind of not providing the same amount of care to women as they have for men. That's a little bit of this gaslighting conversation that's out there. And lastly, the women. The women haven't gotten this message. I brought up this breast cancer issue. We all know about that, but women don't think that heart disease is her number one problem. There was a really interesting study that was done. It was 1,000 women. It was a small survey. And the question was asked, How many women in this room know that heart disease is her number one health threat? And this was a group of really educated women, and like 98% were like, we know it's heart disease, which you're so excited for, right? And then the next question was asked, how many women think that it is her problem? Are you ready for this? 13% said it's my problem. It's everyone else's. I think women feel guilty if they have a heart issue. I should have exercised more. I should have dieted more. We got those messages, but we didn't really get the message that if you have a heart, you're at risk for heart disease, and it's not your fault. There are things that we can do, but if we don't do it early enough and understand that prevention has to take place as early as we can in life, that it's about who we are holistically, not just what we eat and exercise. There's so many factors that go into it that we'll talk about, that if we don't address those, that's when you're at risk for heart disease. But it's certainly not our faults.
Okay. Well, I love that message. And there are a lot of questions I can see coming through, and we are going to get into specifically menopause, the menopause transition and heart disease, as well as, treatments, including hormone therapy. But maybe, let's talk a little bit about diagnosis, or what are some of those terms or biomarkers that, every woman should know, especially as we're having both for ourselves as well as having conversations with whether it's primary care physician or with our doctors. What are some of those terms or areas that women should know about?
So one of the things that happens with so many different diseases, and I'm going to bring up breast cancer again, if we're trying to figure out if we have it or we're at risk, we know there's a gene to check, and we know we can get a mammogram. It's easy. Heart disease is a little more complicated. We can't see it, feel it, or touch it. So like, what do we do? And there are multiple different ways to assess whether you're at risk for heart disease. The first thing I have to explain to you that's so important is that heart disease, and when I talk about heart disease, I'm specifically talking about the buildup of plaque inside the arteries, atherosclerosis that leads to coronary artery disease. It's based on risk factors. The American Heart Association talks about life's essential 8, and that's blood pressure and cholesterol and sugars, and what your weight is, being overweight or obese increases the risk. And then it looks at some of your lifestyle factors like diet, like exercise. I think we all got the smoking message and vaping not being good. And the last one is sleep. And if we look at what risk factors lead to heart disease, those essential 8 are critical. But what they don't talk about are some of the others. Family history matters. It really does. And some genetic markers that we can test for in the bloodstream, like lipoprotein little a, talk about biomarkers, that increases your risk. But there are other things, inflammatory markers, inflammatory disease that happens more often in women, like lupus or ulcerative colitis or rheumatoid arthritis, and other issues like adverse outcomes of pregnancy, gestational diabetes, preeclampsia, miscarriages. So now what I'm trying to tell you is this isn't an old woman's disease. This is going to happen really looking at who you are in the whole spectrum of your life. We talk about pregnancy almost as a stress test, a metabolic stress test, the first time that your arteries are challenged. So when you have any adverse outcomes of pregnancies, it means there's a problem with those arteries, and it's showing up at that time. Other things that we need to look at in evaluating the heart are physiologic and functional issues. How well are the arteries dilating? And there are actually some tests that can look at that. And anatomical issues. Is there calcium in the arteries? And that we can see that through a coronary artery calcium score. But knowing your risk factors is the first step. And then getting tested, really getting those blood tests, checking the cholesterol, the sugars, knowing what your metabolism is. Can you process fats and sugars properly? Are you pre-diabetic? All of these things play a role. Checking the inflammatory markers, checking lipoprotein little a, this genetic marker, all of this matters.
Gosh, it's so many, and hats off to you and every single doctor who is keeping us checking on these and making sure that we're aware. I think if we were, and I'm taking all of this, if I were to write all of these down, there's so many factors at play, like you said, but if we were to boil it down to like you said, before a woman goes in to book a visit with her doctor, are there certain symptoms or signs that we should be monitoring in advance? And are there specific tests that you request, or is it really, and again, I'm getting into the very basic, how do you, if I were to take action today and book that visit, what would I do to make sure that I'm getting the top tests and diagnostic care that I can?
So let's go back to exactly what I was just talking about, these risk factors. It is so important that you know your own personal risk before you actually start the conversation. Mm-hmm. So we know that the incidence and risk of heart disease goes up around perimenopause or menopause. But even before that happens, knowing your family history, is there a history of coronary artery disease, early heart attacks and strokes, blood pressure issues, cholesterol issues? And if that is the case, then testing should happen at 20 years old. That's when you should really begin. If it's not the case, then understanding your risk based on your family history, what is my blood pressure, my cholesterol, my sugars, all of those things are a simple blood test or a blood pressure check. Mm-hmm. And around this time, it becomes important to know what your risks are. What's really interesting is the testing is evolving, because we know disease in women's arteries happen very often in the smaller arteries, and they present itself with stiffness of the lining of the artery called the endothelium. And there are some screening tests that can look to see if your arteries are dilating as well. Standard of care stress tests actually misses disease in women very, very often because it doesn't look at the disease that most often happens in women. And even the invasive angiograms that we often send patients to when we're really concerned about a heart attack can miss disease in women because it happens diffusely in the arteries instead of one location. And why that's important is because it's hard to find and often hard to diagnose.
And I know so much of this is, as we go through Let's Talk Menopause, and I know your life's mission is to empower women to, go in and advocate for themselves. One final question on testing before we move through. What age, when do you start testing? Are there certain tests at different ages that we should be considering?
Like I just mentioned, you should begin at 20 when you have a strong family history. Okay. So you're sitting here at 55 and you're like, should I start? Is it too soon? No, never too soon. 20 years old, you have a family history, go. But I think every woman, and of course you're talking to someone who believes so strongly in prevention, that after we're about done having babies or around that time when you're getting your blood tests anyway, that's the time to really understand what your risk is, because that's the time that you really want to start embracing your health for the future. It's a shift in hormones. All of a sudden you have this little person in your life, so you're in your 20s and 30s. This is the time I would really suggest getting your blood tests taken, and looking for the blood pressure, the sugars, the cholesterol, really understanding your metabolism at that point. And as we go along and we get into perimenopause and menopause, this is when more advanced screening might be recommended. And things like a stress test or a coronary artery calcium score, a screening test for the lining of the arteries looking for calcification. In my worlds, I look really at the health of the arteries, the lining of the artery, and through a deso, I do a very special blood test that really looks at how well those arteries are dilating and if there's microvascular disease, which is really what we want to know early on.
Okay. Well, thank you. Since you brought up, hormonal shifts, and especially, and I think most people on the call or, online here probably, and seeing some of the questions, there's a lot of questions around what's happening to your heart health with hormonal changes. And so maybe we could just talk a little bit about how declining estrogen or hormonal changes impact the heart, and what risk factors we why does it increase, and what we should be keeping an eye out on.
It's so interesting how powerful this estrogen is. And when we started this conversation, I talked about 1993, and that was the time that the Office of Women's Health opened up. And it took us so long to even understand the impact of estrogen on the arteries. We're so far behind. But what we do know is that as estrogen decreases, that lining of the artery, the endothelium, does get stiff. And with that stiffness, we have an associated increase in blood pressure. These risk factors go up. With a decrease in estrogen, there's an increase in cholesterol. We have a shift in our metabolism. Our belly fat increases, our metabolism of sugar slow down, and we are in the perfect setup for the development of heart disease. And it all happens with the reduction of this estrogen. We even have a shift in our cholesterol. The bad cholesterol, the LDL, goes up and the good cholesterol starts going down. So everything changes. When we look at the lining of the artery, there is actually a decrease in nitric oxide, which is really what helps us dilate the arteries. And there's an increase in the hormone that clamps down the arteries. And that's exactly the biggest problem. When we look at a lot of the symptoms that develop, chest pressure, shortness of breath, it's all, or even palpitations, it's
I was going
all.
to ask about palpitations. We hear that all the time with women rushing, even to the emergency room, thinking that they're having a heart attack when it's hormonal changes with heart palpitations.
It's amazing. It's from this decrease in estrogen that can actually clamp the arteries. But also what happens is as that estrogen decreases, we become more sensitive to adrenaline. We actually become more sensitive to our stress hormones. Now think about that. We are not sleeping well. We are totally under stress. We don't know what's going on. We're living on stress hormones. And that is literally driving our systems up. Our autonomic nervous system that balances things out are out of whack. And now we have hot flashes and palpitations and microvascular disease, and everything is the perfect storm to really make us feel terrible. And it's all because of this imbalance between what happens with the arteries and our autonomic nervous system.
Mm. Well, I know we've talked about this, in the lead up to today. We do know that men and women exhibit, signs of heart attack differently. I know you mentioned, you've got that classic case of a man in a movie clutching his heart or an arm pain, but women, do express heart attacks and certain cardiovascular events differently. And so, maybe you could talk a little bit about that.
Yeah.
Just to make sure, because I know, especially I've had this where I've put on a monitor to make sure with my heart palpitations to kind of check myself.
Yeah.
Just what should we be really keeping an eye out on, and how these kind of cardiovascular events manifest?
It is not often, if you think about it, that we've seen women in movies or television have heart issues. And we learn a lot from entertainment. We know exactly what a man looks like. But in general, we are just more subtle, and so are our symptoms of heart disease. We do get chest pressure or pain. I often hear my women patients say, it's not pain, it's more of a pressure feeling.
Mm.
But we also know that they get shortness of breath equally as much as chest pain. There could be jaw pain, back pain, nausea, vomiting, flu-like symptoms, or even sleep disturbances. And oftentimes when I give this talk in public and I say this to women, everyone gets incredibly uncomfortable, especially in New York. I think so many New Yorkers live that way every single day. It's like, how do you know? To your
Yeah.
point. And I think this is when exercise becomes really important, because when you're doing something that's physically demanding, your heart is put to the test, right? And if you're used to exercising in a certain way and all of a sudden it's too hard, or you feel exhausted, or you're getting that shortness of breath more than usual, or jaw pain or back pain, that's how you can tell. That's your real stress test of saying something might be wrong. And as I said, if you have a heart, you are at risk. And the worst thing that you do is you get it checked and you're fine.
Mm-hmm.
Really, what we need to do is just say, am I okay? And I love what you brought up. We have tools right now. You check your own pulse. You know if you're okay. We have that on our watches to see if we're okay. And I think that really empowering ourselves with this knowledge allows us to really check ourselves and know if we need more help.
Yeah, and I love what you brought up of using exercise as a litmus test. And you know, and again, I know there's a lot of questions about hormone therapy and preventative, you know, preventative steps we can take. So the so what, right? We're running through the risks, and we'll get to the so what. But you know, I'd love if we could briefly also touch on, are there different groups of women where cardiovascular health or risks present differently, whether that's Black, you know, Latina, whatever it might be, just as we talk about differences across, you know, across different folks, just to keep in mind.
Statistics show about 55% of African American women over the age of 20 years old have some form of heart disease, and it's usually
Wow.
in the form of hypertension. I will say, in this population of women, we all need to watch our diet and exercise. But when you have a family history of this kind of blood pressure issue, medication becomes your friend. It's really what is going to prevent heart disease and stroke. And we know the incidence of heart disease and stroke is higher in this population because of this. Latina women get diabetes more often than all other cohorts of women. So they're at risk for heart disease for that reason. And we know Southeastern women get heart disease more from this metabolic issues.
Mm,
So the belly fat, which causes insulin resistance. And so it's really so much, it goes back to knowing your family history in a lot of ways and understanding that. Um, Across the board, it is just true that all cohorts are misdiagnosed and the risk factors are missed. So we're not
mm,
getting the same amount of care. And
mm.
peace is so critically important for all women to understand.
Okay. And we just got a question that came through that I think, you know, quickly worth responding to, which is just, who is the best physician to coordinate these tests? Is it your PCP? Is it a cardio? When do you go to a cardiologist? When, you know, when should women start to think about their expanded care team?
I think you start with your primary doctor, and this person really needs to be your partner in healthcare. So if you go to your doctor and they tell you you're fine and you get dismissed, either find another doctor or go to someone else. I mean, we are at the point where we really have to learn to be our own best self advocate. And so start with your primary doctor, get your risk factors checked, get that doctor to really guide you in understanding that person most likely knows your whole history. So help you understand, if I had preeclampsia, am I at risk? And with all of these risk factors, if you have many of them, that might be when you want to go to a cardiologist for further testing.
Mm-hmm. Okay. Yeah. And there was someone who also commented that said that their cardiologist did not believe that menopause had an impact on cardiovascular health in terms of ordering blood tests. And so I don't mean to speak for you, but I would assume that that is likely not, you know, it might be time to advocate for a different doctor.
I'm fairly certain you can speak for me in this situation. I'm going to not say what I think, but I have
Okay.
to tell you, that if
Okay.
a doctor tells you that menopause does not have an impact on your heart, that is not your doctor. That's
Yeah.
not your doctor.
And there, I'll do a small plug. I mean, obviously, you have incredible resources, and read your book. But Let's Talk Menopause also has incredible resources on, you know, finding a doctor, starting to advocate for yourself with a doctor. There are resources to be able to find local menopause experts in your area. You know, if it's not a cardiologist, at least a menopause expert who will listen to you and who does understand and believes that you know, that hormones and hormonal health is so critical to long-term preventative healthcare. I'd love with that to maybe shift into, because it's, you know, the Q&A section is just flooded with questions around just, you know, let's talk about treatment and preventative care. Where are we today, and what should we consider as we're taking care of our hearts?
The way that, and I think it's important that everyone understand this, the way that cardiologists work is that based on your risk, it is now after that determined how you're treated. So if you're at low risk, you're told diet and exercise. And if you're at intermediate risk, it's a flip of a coin. You might have more testing. I believe that when you get through the perimenopausal, menopausal period, we're all kind of at risk, right? We have no more estrogen left. And so if this is the point at which your cholesterol is going up and your blood pressure is going up and your sugars are going up, and you're working on that switch in terms of your diet and you are exercising, and let's talk about that diet for a second while we're going through this.
Mm-hmm.
I think the Mediterranean diet is really probably the best diet for cardiovascular prevention. So what that looks like, leafy green vegetables, lots of vegetables, things like nuts and avocado, olive oil. These are very high in omega-3 fatty acids, which are really critical to arterial and actually brain health, but also incorporating ancient grains, farro, spelt, amaranth, barley, like those things, which actually include protein. And eating protein is a challenge because everyone just wants to go for the meat and the turkey and the chicken. And I'm telling you, a high saturated fat diet is not the best for your arteries. So getting your protein from other sources becomes really important. But that Mediterranean diet is really the best for not only moderating cholesterol and your weight, but also keeping your sugars down and improving heart health through those omega-3s. Then we go to exercise. Now, this is going to be groundbreaking for some of you because back in the day, we really believed that if you are exercising till vomiting, till you're about to pass out, it was the best thing for you. And that is just not the case. But really, 30 minutes of moderate intensity exercise where you're able to talk, but maybe not finish a sentence, is probably the best place for you to sit. And 30 minutes, 5 days a week is really the sweet spot for cardiovascular disease prevention.
Mm.
Strength training twice a week, getting those major muscle groups helps increase the mitochondria in your body and really is part of a preventive strategy. And then we go down to these risk factors, that blood pressure, that cholesterol, the sugars. If in spite of everything you're doing, these levels are still high and you're going through menopause, I'm going to suggest you consider medication.
Mm-hmm.
You're not a failure. You didn't mess up. Don't feel guilty. This is what happens. And if you broke a bone, you would get a cast. Think of it the same way. You cannot fix all these things on your own, and you shouldn't have to at some point because you will just get sick trying. And if I'm telling you 80% of the time heart disease is preventable, just take the medicine because it's better for you than not doing it at all.
Yeah.
Women who are really suffering and going through this, and we are seeing an increased risk of heart disease, hormone replacement therapy is one of those things that can really prevent the cholesterol from going up, the blood pressure from going up, and protect those arteries. In my world as a cardiologist, I don't give or recommend it orally just because the risks of clotting goes up, and I have people who do have plaque in their arteries, but there is no risk. Really, and again, talk to your doctor because there is no such thing as no risk depending on the patient. Okay. But taking it in a different way as a patch, as a cream is really relatively safe.
Okay. And I'm going to repeat that again. Going on medication is not a failure. In fact, it is a really powerful tool in your toolkit. And so, I think obviously the big one here is going to be MHT or HRT, however we want to call it. But there are some questions here around statins and some others. And so just maybe if we could talk about some of the, call it non-hormonal before we move into HRT and that impact. But yeah, can we talk a little bit about statins, lowering cholesterol? I just want to make sure that I'm hopefully covering some of these, and I might pepper in. But yeah, can you talk a little bit about statins for
Sure.
a second and when to consider those?
Yeah. So statins got a really bad rep. Okay, so we all know maybe about the Women's Health Initiative. That was this horrible study that told us that women should not be on hormones because it was dangerous, that we know is not true. I'm going to tell you the same sort of thing happened with statins.
Mm,
Research around statins have really showed that for women, it doesn't prevent cardiovascular disease and major stroke, heart attacks. I'm going to tell you, it all depends on how the research is done, depends on whether or not it's actually accurate. And we do know that statins does prevent cardiovascular disease. The way that trial was designed does not focus on the most common form of cardiovascular disease and how it presents in women. And so we do know if that cholesterol's up, that LDL cholesterol is up, that, and you have multiple risk factors, it is a preventive strategy. If you have had an event, it's 100% given that you should be on statins.
okay, thank you for that. Maybe let's get to HRT, MHT, HT, hormone therapy. Can just talk a little bit about its preventative benefits or not. But can we talk about HRT and its impact on cardiovascular health?
It's really interesting again to look at how powerful estrogen is on its own. And as I mentioned before, I don't really recommend for my patients as a cardiologist that they necessarily go on oral. But that really, as a patch and as a cream, HRT can be very, very helpful because what it does is it increases that nitric oxide and it
Mm,
decreases the hormones that actually cause the arteries to clamp down. And so we're getting this benefit of arterial dilatation. And let's think about that. There are arteries from head to toe. If you dilate the arteries in your brain, you're going to help with that little cognitive thing that sort of gets messed up during perimenopause and menopause. And certainly you're going to help decrease the blood pressure and help with the metabolism issues and perhaps bring that cholesterol down a little bit, maybe. But I do think it is part of a strategy that is appropriate for most women, not all women. And those women that have a uterus need to be on progesterone as well. But tailoring that and the doses of that really takes some nuance and finesse. And so you need to find the right doctor to actually help you on this journey. I don't think it's the kind of thing that I do recommend, get it by yourself and dose yourself. I don't think that's right.
yeah.
Um, Women are like, but I can't get it. I'm like, you can get it. Just go find the right person. And right now, there are virtual platforms out there with women doctors who are really tailored and catered to understanding the role of hormone replacement therapy in menopause.
Okay. And, is it too late? Or this is a couple of questions from the audience. So I'm going to ask these kind of word
Yeah.
for word here. But while we're on the topic, is it too late or dangerous to start menopause hormone therapy after a woman has high cholesterol or blood pressure? How do you think about that?
No, I don't think so. So the timing hypothesis was that it was very, very clear that within the first 10 years after menopause,
Mhm.
that hormone replacement therapy is really effective in preventing cardiovascular disease. I think that is now clearly the message that we've all gotten, or most of us should have gotten, that within that first 10 years postmenopausal, go on hormones, go on it early and quick, because that's your sweet spot for prevention. But if you don't go on it until you're 3 or 4 years in and your cholesterol's are already elevated, it's not too late. And I would really suggest that you try it.
Okay. And what about over 60? Because that was a question. Let's say a woman, experienced menopause at 51, but is considering MHT after 60. Is there a risk factor for cardiovascular disease?
There are some studies that show that really there's a cutoff, but maybe that it is safe. And we're seeing more and more showing that it might be safe after 60 as well. I think that that this one is not set in stone quite yet. I don't think, again, how you take it, whether it's orally, vaginally, or by patch, makes a difference. And
Mhm.
certainly over 60, I think that taking it orally would not be recommended, but really having that conversation. Now it comes down to, what are your risk factors? What's your family history? What else is going on, to really understand if it would be the best thing for you.
Mhm. And this is where, and this is like the call to arms for anyone who's working in women's health. We just need more research. We need more funding. We need
Yes.
everyone on this call and beyond to speak up and out, even if it's just speaking with those around you, or whether it's with your representatives, your company, wherever it may be. The louder our voices are to get more research, the better we can answer these questions. That's my soapbox that I'll get on for a moment here. But can we talk about, there are some questions from women or folks in the audience who are not able to take MHT, either because they have a history of MI, which myocardial infarctions, or stroke, or they're just not able to because of family history. Can we talk about some options for maintaining optimal cardiovascular health for those that are unable to take MHT?
I think this is a really important question, because I think as the menopause swell has gone on, and really people are really hearing this, and for the women that can't take it or don't want to take it, they feel like they're missing out. And I want to say that when it comes to cardiovascular prevention, I get how you feel, but there are options. And that when it comes down to it, we are going to focus on diet and exercise and sleep. And I cannot believe this, but I didn't bring up stress management, because I talk about this ad nauseum. I think that we really underestimate the impact of our brains on our hearts. And I want to answer this question and come back to this. But it comes down to really mitigating those risk factors and controlling them. So if your problem is high cholesterol, I'm not telling any of you to take estrogen instead of a statin. I'm telling you to get that cholesterol down. And so if we do the diet and exercise and your cholesterol's still up, you can take a statin, you can take blood pressure medication that actually protect the lining of the artery. You can actually take supplements that increase the nitric oxide in your arteries and help them dilate. You can really do holistically so many other things to protect you, to really prevent disease. That estrogen is not the end all be all in this story. It's a part of the story. And that goes for all women. It's just a piece of it.
Mm-hmm. I love that. And, it is easier. And I take that advice very much to heart. I also know that it is, especially for anyone here who feels like they're juggling, a million and one things. It can be tricky, but the importance of reducing cortisol and stress, like you said. I'm living proof of this. I've made a lot of lifestyle changes for myself in the last year on my end. I had some somewhat scary and eye-opening heart cardiovascular tests about a year ago. And now with, I will say, a reduction in stress, it's just been amazing to see that. And so that is without, some of the hormone therapy or some of the prescriptions. And it's a complete package. And again, important to focus on that.
I think what's interesting is we have seen through studies that on the heart cells, on the heart, there are the same cells that are in the brain. So our hearts are actually like little brains. It is carrying us. Women are heart centered.
Yeah.
Men get stressed, they get a headache and diarrhea. Women get upset, we get palpitations and heartache, because we live from our hearts. And what that means is, if we don't pay attention to the effects of all the toxicity around us or that stress, it is literally affecting our hearts. And as you mentioned, that cortisol, that inflammatory marker, is toxic to the lining of the arteries, and really is part of what leads to atherosclerosis and coronary artery disease.
Mm. Okay, so I'm going to move through some of these questions, and I'm going to, I think, hopefully capture these and communicate. So if having a history of a heart attack is a contraindication to hormone therapy, Why is hormone therapy indirectly helpful for heart health? Uh-oh, the question just moved. Um, but I think the question is, if you have a family history, um, it's this catch-22, I suppose, of wanting to be on it, but understanding if you have a family history.
So if you have a family history of heart disease, that doesn't mean you can't be on estrogen. But
Okay.
the mechanism behind it is really to deal with that lining of the arteries. And I'm just going to go back to this physiology. That lining of the artery, when it gets stiff in those early stages, the estrogen can help reverse that stiffness. As the disease progresses, what happens is that lining of the artery develops micro tears, and inside those micro tears, cholesterol goes and inflammatory cells go, and that is the buildup of plaque. And as plaque builds up, it becomes calcified. Now, when we have calcified plaque and some non-calcified plaque that can rupture and lead to a heart attack, the estrogen doesn't have as great of an impact because the lining of the arteries are now diseased.
Mm.
We know that estrogen is so powerful and potent before that disease develops. But when that disease is there, like after a heart attack, it's just not as effective because of how I described the buildup of that disease in the lining. And I hope this is really clear. Not that you're going to have to repeat it to me,
Mhm.
but I want it to be clear of the reason why. And so, what we're trying to do is say, how do we prevent this from developing? And if we have it, how do we prevent ourselves from ever getting a heart attack again? And
Mhm.
it goes back down to those risk factors, that cholesterol low, that blood pressure low, that sugar's low, diet, exercise, sleep, stress management, and it's possible.
Okay. Um, there was a question actually about testosterone, and I'm curious how testosterone potentially plays a role here or not.
So, not necessarily in cardiovascular disease.
Mhm.
We're doing a little experiment in my practice here with some patients because it's not really used as standard of care right now. I always describe it to my patients as saying it gives you your mojo back. It's really part of what testosterone decreases as we go into menopause. It's a natural part of our bodies in the level that we have it. Giving a small dose of testosterone, not a high dose to transition you to a man, but in a very low dose for women, it increases your energy and it can increase, again, your sexual desire and all of those other things. Testosterone, when used too much or incorrectly, can actually increase your risk of cardiovascular disease.
Wow.
Something that could be given, it needs to be monitored and given in the right way. So in my office, what we're doing is actually testing the microvascular, and all the women who are in hormone replacement, we test again 4 months after, and we see if those arteries are getting better or worse. And spoiler alert, they're all getting better. And so I'm working with a gynecologist here focusing on menopause. She's like, wow, wow, it's very exciting. It's really cool to see that women are getting better.
I love to see that and bringing that data that is so desperately needed to say this is, safe and effective.
We're doing that. That's part of Adesso. We're collecting thousands and thousands of women patient data just to show, hey guys, it's really not as bad as it was.
Yeah. Um, there was a question here about supplements. We know that diet and exercise and stress management and all of these are the best. But can you talk a little bit about supplements, especially as we in this era of the perimenopause and menopause gold rush? What supplements or vitamins should we be considering or not?
This is actually one of my favorite topics because there's been so much bad press around supplements, as there should be. And there were major trials that really showed that they were not beneficial or helpful for everyone to take supplements. It's not going to help everyone. Well,
Mhm.
I'm sure by now you've realized that I don't look at prevention as one size fits all, and I don't believe in supplements as one size fits all either. Guess what? We can actually draw your blood and test if you need certain vitamins. And so I don't give it without testing and making sure we're at the levels we need. But the vitamins that I do recommend to be checked and tested are omega-3s. I think they're critically important not only for heart health, but brain health, that they go together. There are arteries in the heart and the brain. They're the same arteries. So if we treat the heart, we're treating the brain. And I think omega-3s are really important. Vitamin D is another one we could check. And it's not, what's so interesting is some of these studies looked at giving a certain amount of supplementation and saying, well, it didn't work. Well, some of us need more than that dose, and some of us need less than that dose. So if it's tailored to you and vitamin D tailored to you and rechecking it, I think is helpful. Magnesium also can help a little bit with palpitations.
Mm,
So magnesium in the form of glycinate and citrate can be helpful. If you take magnesium oxide, it just helps with it helps with constipation. It doesn't really help with your heart. So magnesium glycinate, I recommend. And L-arginine is also a precursor to nitric oxide. And so it can help those arteries dilate, the microvasculature to dilate. So sometimes for palpitations, a little L-arginine and magnesium is actually one of the best. Oh, and I'm going to throw in exercise, because exercise is actually the most powerful thing to decrease hot flashes. So if we throw in a little L-arginine, a little magnesium, some exercise, and maybe a hormone patch, that's probably your sweet spot for palpitations.
perfect. Well, I know we have just under 10 minutes left. I've already learned so much. There are some questions here that I'm going to go through in maybe rapid fires. This is going to be the rapid fire questions. And then we'll, would love to wrap on just, I'll give you some time to think of this, but the, 2 to 3 things that coming off of this call, you do recommend every woman do to make sure that they're taking ownership of their health. You've of course, given a lot of things to think through, but, always excited to see, when the call ends, what women can and should do. But really quickly, rapid fire here. So cardiac calcium score test, how to interpret those results?
So it's very challenging because that is one of the most recommended screening tests for heart disease in women. I described for you the exact pathophysiology of how plaque develops. That calcium happens in late stage plaque. So it's actually not telling us if there is soft plaque or early plaque in the arteries. It's only telling us if there's calcified plaque, which is a later stage.
Okay.
When you get a calcium score and it's 0, it doesn't mean that there's no plaque in there. If you have a calcium score of 50, it tells us that you probably have immature plaque behind it that is going to become calcified. So through cardiology, the guidelines say no statin until your calcium score is at 100 because it becomes more critical. In my opinion, that's waiting too long. That if we know that a calcium score is starting, then you should start on medication to stop it. And so how to interpret it is simply that. If you have it, you know that there's younger plaque, baby plaque growing, and you are at risk of heart disease. But a score of 0 doesn't mean enough for us for me to say it means everything. If a gynecologist will not put you on hormone replacement therapy without a calcium score, I'm not sure if that's the right strategy because you could have soft plaque there and you just won't know.
Okay. Well, I think this might go, and again, with an eye to time, I'd love to wrap with you, your amazing work with Odessa too, in terms of empowering women to understand their risks. Maybe again, hearing a little bit about what are some of the, what you recommend women can do today. And then I will also plug on your behalf, Odessa, because there's some incredible either self-assessments or diagnostics that is my recommendation to close this with, of making sure that you're going to Odessa to take some of the incredible resources that you've already put out in the world.
Thank you. I really want to say that Adesso started because of my frustration, having been in the hospital system and in research and this whole field for my whole career and having no change in the statistics. I thought, how are we going to do this? And so the first thing that we created was the Adesso Heart Score. We are in the Apple Store and Google Store under My Adesso. And the first thing is that you take your risk assessment and really know what your risks are. And it's a self-reported questionnaire of really talking about all the things that I talked about today. Play it back if you need to, but it's really talking about not only the risk factors that we can get from our blood tests, but understanding that adverse outcomes of pregnancy, your family history, that stress, PTSD, certain things like that actually also increase your risk. But getting some objective data is critically important, and knowing your real risk assessment, your personalized journey to prevention starts with knowing your risk and your family history. And that's the first thing. Then really understanding what the physiology is in your arteries. And where we are now in Adesso, we use a cardiopulmonary exercise test, not only using VO2 max, but really looking at arterial health to determine if your arteries are healthy. There are some screening tests out there besides this that actually look at arterial health, and you can find them to see if your arteries are stiff or not. Coronary artery calcium score, stress testing can sort of tell you, but not exactly. But understand that a lot of this is in your control. And I think this is something that people miss. If you really get down to exercising 30 minutes, 5 days a week in this moderate intensity zone, and you really start watching your diet and making sure you're not eating sugars and cutting back on those saturated fats, you've done so much. And then all of a sudden you add the sleep factor and the stress management factor. You have done so much. And then when you know what your risks are and going into the doctor and really addressing them one by one, I had preeclampsia, I had gestational diabetes. That means you're going to have a 75% greater chance of having a coronary artery calcium score later in life. Well, then maybe you should get one. And now you see you're at risk. That would be the time I would consider medications. But the most powerful thing you can do is knowing your risks, knowing that exercise is by far the best medication for everything. And then I think the last piece of it is that the more you're educated, the more you're empowered, and the more that you are empowered, the more that you can change your life. For me, perspective is everything. We spend so much time thinking of all the negatives, worrying about what we can't do, what we can't control, what we can't manage. And I will tell you that optimism is our natural state of being. But if we force ourselves to really be pessimistic and understand this is scary, we got this, there are enough people out there giving us information and providing us tools. I advise you to go to adesso.health, check it out, and it really gives us some information that if we can really flip that switch from optimism to pessimism and know you can do this, you switch the nervous system. And what that does is it decreases all those stress hormones, it decreases cortisol, and it can actually help prevent heart disease because 80% of the time, heart disease is preventable.
It sends shivers down my back. Thank you. That was really empowering. And I appreciate the balance of optimism and pessimism here, of just arming yourself with knowledge. I feel, so much smarter and more empowered myself. So thank you, Dr. Suzanne Steinbaum. We are so grateful for your time. I know there were more questions that we wanted to get through, but hopefully we will try to address them in our upcoming newsletter. Thank you again for your time here, and just excited to continue the conversation, research, and advocacy that you've been doing in cardiovascular health. So thank you.
Thank you.